Welcome to another episode of Parálisis Cerebral Respuestas. This time we're live from the American Academy for Cerebral Palsy and Developmental Medicine. And I have the pleasure of interviewing two doctors from Sweden, so very, very far away lands, a country that I have been to because my brother lives in Finland, Helsinki. So it's a beautiful country. Hopefully I get to visit very soon. But they were the presenters of a session that was very popular. And as I told them, no one could fit in that room, way beyond 100 attendees, I would say. So congratulations to both. I'll start by I'll let her introduce herself, my guest on the left, because we're all sitting in the table. And so, we'll start with my guest on the left.
Thank you so much for inviting us to this podcast. So my name is Cloodt. I'm a physiotherapist by background, and I work half-time with research on contracture development in children and adults with CP. Mm-hmm. And I work half-time in clinic, meeting mostly children with CP.
Okay. So do you see children of all types of CP?
Yes, all types of CP and all ages from 0 to 18.
Oh, wow. Okay, incredible. And then we move to my guest to the right.
Yeah, my name's Ferdinand von Walden. I'm a senior resident in pediatrics, soon starting my fellowship in pediatric neurology. And I'm also, as you said before, a complete muscle nerd. And it's been since many years. I'm a associate professor of physiology at Karolinska Institutet also. And dedicate quite a lot of my time to look at muscle and exercise and how it adapts in kids and adults with and without disability.
Right. It's a fascinating topic. And I guess that's why, there's a lot of people in your session. And just so that everyone knows, their session was EDU 75, the whys and hows of contractures and deformities in children and adults with cerebral palsy, implementation of a multi-professional surveillance. But before we start, as I mentioned before we went on air, I like to ask my guests questions that have nothing to do with their professions because, a lot of your patients, I don't think they get to see you outside of the medical setting, right? So at least, I don't know if any of my listeners will go to Sweden and be your patients, but at least they get to, hear from you and know facts about you that they would never know. So Erica.
Yes.
What is something very random about you? A random fact about you? Do you have a special talent? Do you scream at trees when you get angry? What do you?
Oh, tricky question. Yeah. I love to play tennis. And I definitely don't have a talent in tennis, I have to say, but I like to play tennis.
You're one of mine. I love tennis. I absolutely love tennis. Like growing up, I really wanted to be a tennis. I can watch tennis. Well, one of my favorite tennis players is from Sweden, Bjorn Borg.
Good.
Yeah. He was the king of clay before Rafael Nadal. I love tennis. So that is very random. Thank you very much. Another question for you. What is a food that you like to cook if you like to cook? I don't even know if you like to cook, but do you like to cook?
Actually, I don't cook that much because I have a husband that do most of the cooking at home. So I'm very fortunate in that sense. So every time that my husband is away at work, my kids are very worried that they will starve because their mother is not so good at cooking.
Okay, and I mean, do they starve? Do they survive?
No, they starve. No, they survive. I can cook pasta and I can cook, but normally I don't.
So just for survival purposes.
Yeah,
okay, the important thing is that the children survive. Okay, off to my guest on the right, Dr. von Walden.
Yes.
If you could pick one of these three superpowers, which one would it be? Knowing how to speak all the languages of the world, invisibility, or time travel?
I'd probably go with speaking all the languages in the world.
Okay.
Yeah, I mean, I know English and Swedish, of course. Know a little bit of French, a little bit of German, but will be nice. I mean, there's still millions of people or billions of people that I can't talk to.
Yeah, that's true.
I would like that.
Okay, so all the languages of the world.
All the languages in the world.
Very interesting. Yeah, I think I would pick that as well. What did you want to be as a child?
That's a good question. I think when I was kind of in primary school, I wanted to join the military for some reason.
What?
Which then absolutely did not happen. I didn't even do military service. So
Okay. Is
and
it mandatory in Sweden? No.
it was mandatory when it was my turn, kind of. That's
Okay.
20 plus years ago.
Okay.
But I had already then kind of started university, so they kind of let me go. Because if you're enrolled in an academic track, that can happen. And I started doing physiotherapy, actually, before I became an MD. So I did 2 years of physiotherapy and then fell in love with physiology and to study more physiology at the university, especially in Sweden. Then becoming a medical doctor is a good entry point.
Okay, physiology.
So the kind of the love and the interest for movement and physical function has always been there.
But you thought you were going to be in the military.
Yeah, but what do you know as a kid?
That's true. That's true.
Yeah.
That's very interesting. Okay.
Yeah.
That is a very random fact. I'm glad that you're not in the military.
I thought I would get the random fact question. I was just thinking of the age.
Okay, do you want
the age of my mustache? Because it's the same as my oldest kid. That's
what is the age of your mustache?
my mustache is 15 years old.
Okay.
Yeah.
So you have a child that is 15. Okay.
Yeah, I have 4 kids.
Wait.
Sorry.
You've kept your mustache for 15 years?
Yeah, it's a pretty random fact.
What? You never shaved it?
No, it hasn't been shorter than 4 millimeters in 15 years.
Okay. Oh my God.
That's a very random fact. Sorry about that.
That is very random. Okay, we definitely learned
Maybe you can edit it out.
No, that's okay. We're gonna keep it in the episode. Okay, so now going into the topic at hand. One of the first things that you mentioned when you started, and I took notes of this, is that you said today's goal is to understand the mechanisms and to identify patterns that can help with conversations with families and people that have CP and how we can make interventions that make sense.
Yes.
So I guess my first question, that is a lot, but I really like how you framed it. You framed it about people and the patients that you see and interventions that make sense. Now, when it comes to muscles and bones and things, how do you, and I'm going to ask you about the different types of muscles and the things that someone, like I'm a woman with CP, how does my muscle look like as an older woman, right? I will talk about muscles, but how do you identify what intervention makes sense based on someone's case in CP, whichever one wants to jump in.
Okay, I think that's a good question and a very, very big question. And unfortunately, we don't have all the answers about how we can treat or even prevent contractures today.
Mm-hmm.
But I think by our work, where we have followed children and now also adults for many, many years in Sweden, very systematically, we are seeing our children and adults every year or several times per year, just to make those measurements and follow-ups meetings. I think that information helps us to guide over time which interventions that can help. But we don't have all the answers right now.
And in Sweden, you have a very interesting thing, which is in 1994, the follow, please, what is the name of it?
It's called CPUP.
It
It's
was
a cerebral
implemented.
palsy surveillance program.
Yes, that was implemented in 1994, I believe, in one part of Sweden, and then it became a world, well, not a world, but a Sweden-wide implementation program, if I'm correct.
It's true.
And that is how you get your data
Yes.
across lifespan.
So in children, over 97% of all children with CP in Sweden are followed at least once a year in our surveillance program.
That's
so we are following almost every child with CP in Sweden.
That's amazing.
That is amazing. And, you know, when I was doing research, I found out that this is a model that, I don't know, has it already been transferred to Denmark, for example?
Yeah.
Yes, it has been transferred to Norway and Denmark and some other countries also in Europe, which are has been inspired of the Swedish model and creating something similar in their settings.
That is incredible. Talk about really follow-up. And that is my next question to you. How, obviously, as we get older, our and you know, from the moment we are born, our muscles change. And you mentioned something about as early as 15 months, you can see the difference, the growth patterns between babies with CP and those who don't. Can you tell me more about that in their muscles in particular?
Yeah, that's data that came out of Denmark about 10 years ago, where they followed kids at risk of developing CP and typically developing kids, doing ultrasounds of the calf muscles. And they could see that already by 15 months, as you mentioned, the trajectories for growth were different, with the muscles of the kids with CP or at risk of CP showing a slower growth trajectory. And these data have been built on now by other groups, also European data coming out. This is data from Belgium, where they've also done repeated ultrasounds of slightly older kids, still below the age of 10. And there they've seen that having a more severe type of CP, so GMFCS 3 and 4, maybe where you're either not an independent walker and you spend time in a wheelchair, that puts you at risk of having an even slower growth trajectory of your muscles. So there's the severity of CP in itself will affect muscle growth, and just having CP will also put you at risk of having slower muscle growth as a child.
Wow. And I'm going to follow up with, obviously, as I mentioned, as a woman with CP, and I want to sort of talk about two different topics here, is the muscles, but then also the formation of the contractures in the upper and lower level extremities, and also scoliosis, which is something you touched on. When it comes to children with CP and people with CP in general, what is the difference in their muscles? I know you mentioned we have fewer capillary muscle, fewer capillary.
Yeah, the blood vessels.
Yes.
They're called the tiniest blood vessels in the body. They're called capillaries. And that's one of the things that sets muscles in individuals with CP apart from typically developed individuals. Another thing is that you have a more variable size of your muscle fibers. Typically, when you look at the muscle section in the microscope, it's pretty homogeneous. If you have cerebral palsy, it's a little bit more variable in size. And between fiber bundles, there's also a bit of extra connective tissue.
What are fiber bundles?
Fiber bundles is good comment. That's a group of fibers, maybe 100 to 200 fibers that are packed together by connective tissue. So that causing we call that a bundle. So it's a group of fibers, you could say. And between these groups of fibers, there's a connective tissue layer. And if you have cerebral palsy, typically that can be a bit thicker as compared to typically developed subject.
Okay.
And this, we think, could have implications for stiffness and maybe being part of why you actually develop contractures.
Okay, and that leads me to the next question, which either of you can respond. For the parents that are listening, what exactly is a contracture?
A contracture is when a joint, you don't have full range of motion, full motion in a joint.
Okay.
So you can't extend or flex your joints
Okay.
to a full extent.
Okay, and people with CP, it depends on the type of CP that they have. Then, yeah. that will
Yes,
determine.
yes.
Okay, and what is the pattern in which contractures develop in the upper extremities, for example?
You mean when they develop, or?
Yeah, is there a way they start to, like, if they don't stretch as much, or I don't know, how do contractures develop? How do they happen?
How do they happen?
Yeah.
We think that the delayed growth probably has something to do with it.
Okay.
So that as the long bones in the extremities, when they grow, muscle can't really keep up. And typically when you're in a growth spurt, that's when kind of contracture development or contracture formation also takes kind of an extra step and becomes a little bit more severe. So impaired growth is probably key to contracture formation.
Impaired growth, what do you mean?
I mean that there's a mismatch in the rate of which the bone, the skeleton, the bone grows and the muscles next to the bone. So when you're in a period of fast growth, like puberty, for example, then your muscles struggle to keep up and increase their length. And therefore we believe, might become stressed and respond by producing a contracture then, which is a stiffer, thinner muscle.
Violet. Okay.
While in children without CP, you don't see that.
You don't?
You see that the muscle is keeping up with the bone growth. So there's a clear difference between children without CP and children with CP.
Is there a age where you can start to see that really, like, clearly when you're looking at the muscle?
We see that contracture development starts very, very early, and we have been surprised by how early it starts. So already before the age of 5, you can see that children are starting to get contractures, and especially children at higher levels of GMFCS. I think that's something that is good for parents to hear. It's not good to hear that your child will probably get some contractures, but it's good to hear that it's not external factors, that it's not something that they are doing. It's something that happens inside the body. So there is a difference when you have a CP that you can change.
Right. So it's not something that the parents are not doing, but it's rather something within the muscle and the body of the child that is developing, that is creating,
Exactly.
making this happen.
And I think a lot of focus previously have been on external factors, that there is those things that you should do. You should stretch, you should use this orthosis, you should use everything. And as a parent, it can be very stressful, and you feel a stress that you want to do everything for your child. So I think it's important that we start to talk more about those factors that actually happens inside the body.
Right. So it doesn't. One of the factors is that the bone and the muscle don't keep up. What is another factor that can contribute to?
We think that that's kind of the main factor. Then why that happens, that's a completely different question. Then we're down at the mechanistic level, and you could either say that could it be that the number of blood vessels, as we said, that you get too little food and oxygen to the muscle? That could be one thing. We know that one part of the muscle or the muscle cell called the mitochondria, which is the organelle or the part of the cell that produces all the energy in the muscle. That is working at a lower capacity, it seems like, if you have cerebral palsy. And we, as of yet, we're not sure if it's a reduced capacity really, or if it's a reduced number of mitochondria. That could also be something. I'm interested in also in the actual process of growing muscles. And there we think that both the satellite cells, the stem cells of the muscle, are important.
Okay, I want to stop you. What are satellite cells, and what are all these cells?
Yeah, exactly. That's a good comment, because when you think about muscle, you think of it as, you probably think of it as mostly the same type of tissue, that all the cells are the same. But between the long muscle fibers that looks like strands of hair, basically, between all those, there's small circular cells that are, they're different than muscle cells. They can be stem cells that can become muscle cells, but they can also be fibroblasts, as they're called, the cells that produce the extracellular matrix, the connective tissue that we talked about before. And there's at least 10 different other types of cells, including fat cells, for example. So muscle is really like, a little world of its own, if you want to say.
That's why you love muscle so much.
You could see it in my eyes when
yes,
I said that. Yeah,
they're glowing. Another thing that you mentioned that I took note of is that genes. What genes are active in the formation of muscle in people with CP? Yeah,
that's. I remember saying that during my talk, and what I meant was that when you study molecular biology, there's ways to ask the questions: which genes are active at this moment in a tissue, and that's been done with CP. Muscle or muscles from kids with CP, and when you compare the signature or the different genes that are active in muscles from kids with CP, they differ from
and how do they
typically
differ?
Developing kids. For example, genes involved in connective tissue formation are upregulated, so there's higher levels of those transcripts, whereas, for example, growth and metabolism is downregulated. So it kind of matches what we think we see when we look at slowed growth, for example, and the stiffness. So the genes are telling the same story. Kind of.
Does that mean that when you talk about metabolism being down, does that mean it impacts the energy level of the person?
It could impact energy production, and it could impact which type of energy your muscles prefer to use, if it's carbohydrates, which is sugars, or protein and fat.
Okay, this is interesting. So I'm talking with you from the muscles and the biology, but you study more the trajectory of the muscles and the growth, right?
Yes.
And I remember you both connecting these things, well, you in particular. How do you see his work reflected in your work when you're looking at the growth trajectories and the charts?
Good question. Yeah, that's mainly the reason why we are doing these sessions together, because we have seen that we can benefit from each other's research. We can tell more. So when we look at our trajectories of the development of range of motion over time, we can see that different muscles are affected to a different extent. Like it seems like, for example, the hamstrings muscles on the back of the leg is a muscle group that is affected in most children with CP, and that range of motion start to decline very early in early age.
Yeah,
and that is also something that has been shown in muscle research, while other muscle groups doesn't seem to be doing that. in the same way.
And do you find? I mean, do you work together, like on a regular basis?
Not as much as we would like. I think
Okay.
we've done a couple of these educational sessions or symposia together. But now we're kind of both at that, at the stage where we realize that we should do more work together. So I think there's fun times ahead.
Hopefully this podcast can be the beginning of trying to combine both of your works.
Exactly.
And one of the things that you mentioned, and I will touch on scoliosis because that's a topic that you also touched on, but how does the GMFS level impact on the molecular level and the cell level, and how does it impact on the growth trajectory and the development of contractures and deformities? So we'll start.
Should I start? Yeah. I should say that most of the things that we know about skeletal muscle and what it looks like on the inside, so to speak, in kids with CP comes from kids that have required a surgical procedure. So that's where you have the opportunity to get a sample, right? You're under general anesthesia and your muscles need to be corrected kind of to allow for full range of motion. So most of the things that I say that we know about cerebral palsy and muscle comes from kids usually with the higher GMFCS levels, right?
Does that mean you don't study people like me who have, who are in the 1 and 2s?
Typically, I would say maybe I should rephrase myself. I should say the bulk of the patients that undergo surgical procedures are typically from the higher GMFCS levels. Have you had many surgeries?
Yeah.
Yeah?
I've had 18 orthopedic surgeries.
18 orthopedic surgeries, yeah? So...
I have spastic diplegia. But I was born, I'm 37, so I was born in a time where they have the birthday syndrome type of thing, where it's like every single year. Yes. So
I think we're moving away from that.
Yes, absolutely. I think so.
And there's, you're trying to postpone larger surgeries until you're a bit older.
Yeah. But you were saying that most of your...
most of the information we have are from kids with higher GMFCS levels, I should say.
Okay. And in your case, I actually forgot the question. What did I...
It was about GMFCS level and how that could tell us something about the contracture development. Yeah. And GMFCS is a functional classification. So it's basically for us to have a common language to describe the level of CP. And in our research, we can see that this classification is a very good predictor for how your range of motion development will look like over time.
Okay. In adults as well, because and in Sweden you have that data, right?
Yes. So since 2011, adults were also included in our follow-up program. Before that, it was only children.
Oh my God!
But in 2011, we started to also follow the adults. Yeah. And I think one of the things we thought back then were that the range of motion probably would stop to decline in childhood. So maybe there was no reason to follow them up in adulthood, but that has clearly been shown that is not the case. It's not the case. So the range of motion in adults continue to decline, and also other secondary problems like scoliosis and pain. Pain is very common in adults.
Yeah.
CP.
And I have 2 questions for you, because I remember at the beginning you said, and I'm talking to Dr. Van Walden, you said something about and please correct me, something about being 90 days in bed or aging. What makes the muscle, what is worse for the muscle? What
I showed there was a slide where we've taken the gene signature, the molecular signature of which genes that are active in CP muscle, and we compared it to older individuals. The same data exists from older individuals, or healthy young men that had been 90 days in bed as part of a simulation of space travel. And when we did that, we kind of went into that experiment believing that it would be more similar to inactivity, but it's actually more similar to aging, which I think, makes you think a little bit.
So that leads me to my next question. I'm a 37-year-old woman with CP. What does my muscle look like now?
Short answer, we don't know. There's not a lot of older adult CP molecular studies, I should say, when it comes to muscle. We're in the making of doing those studies, so we'll know more in the future. But just extrapolating from what we know now, already teenagers with CP, there's a lot of features when you look at the muscle in the microscope, for example, that actually resembles a little bit older individuals in aging. You have the variable fiber size, you have the fewer capillaries. When you test the mitochondria, there seems to be fewer, or at least they're working a little bit less efficient. So some people, and I'm also involved in those discussions, talk about CP as maybe it's it's a feature of accelerated aging or a little bit premature aging. The good side of that, I think, is that, for example, exercise should then be able to, reboot the system a little bit. And that's also something that I'm hypothesizing. We don't know these because we haven't done those studies either. But we know from typically developed subjects and a lot of other disease states that exercise has a rejuvenating effect on systemic metabolism, for example, and the muscle as a tissue. So I think there's, you can't stress the importance of physical activity enough, I think.
But then that becomes a challenge, because what about, the individuals who are in the higher levels of CP, right? Who can move, they're in their chair and they can move, but perhaps not as much as someone, at my level, or, because it's so different. Then in that case, what happens when the mobility is limited?
I should say you should always strive to find your type of adaptive physical activity. I'm a frame running fanatic, and I guess we can save frame running for another episode.
Yeah.
But it's a type of physical activity, if I'm just shortly explaining what I mean by that. It's basically a tricycle, but it doesn't have any pedals, and it allows for people with pretty severe motor dysfunction, or GMFCS 3s and 4s. We have also individuals with GMFCS 5 that can run on a track with these frames.
I tried one yesterday for the first time, by the way. Oh my God.
How was it?
At first I was scared.
Yeah.
Because I don't know how to ride a bicycle. No one has really ever been patient enough to, teach me how to ride a bike, and I don't drive. So, and I don't know how to swim. I should add. I love walking.
And taking the bus.
And taking the bus, yes. So I got into it, and one of the doctors, he helped me get into it, and it took like 30 minutes for him to convince me to, try it. And I was like, okay, I'll try it. And I tried it, and I was like a little bit uncomfortable at first because it wasn't adjusted to my height, but after a while, I was like, oh, I got this. So I was going around the exhibit hall and just crashing into everyone, because obviously I have no sense of direction. And then going backward, it was fun. So I loved it. So yes, when I was in Germany, I think I told you, I interviewed one of your students, Emma
Hjalmarsson, yeah.
Yeah.
Okay.
And your Swedish is much better than mine.
Yeah.
So I interviewed her, and she talked about her graduate studies in frame running. She did a lot.
Yeah, she's a former student.
Yeah,
She has her own thing now.
Yeah, so it was a lot of fun. So I look forward to going to Sweden and inviting you. Well, not inviting you. I would be the one who's invited to.
We're glad to have you over for a frame running focus
I
episode.
am so happy. I'm so excited. Looking forward to that. And finally to end the episode, because I know you're very limited on time. You mentioned about multi-professional surveillance and this whole idea too. How does it enable detection, prevention, and treatment in contractures and deformities?
Yes. So in Sweden, we are doing this annual follow-up meetings with the children and the families. Mm-hmm. We're doing this together with our team. So normally we are seeing the kids, the physiotherapist, together with the occupational therapist, mm-hmm. the speech therapist, and we are meeting them together mm-hmm. to see the whole picture. And then we also have a conversation with the orthopedics, with mm-hmm. the doctors, around the findings that we had mm-hmm. during the meeting. Mm-hmm. So I think that's a way to see the families and the parents as part of the team. Yeah. So we have this trajectories that you talked about. Yeah. We are showing them to the parents as well, so they can see how the range of motion have changed over time and what they have answered the previous years. So we can also follow in combination with what kind of treatments they have received. We can also follow the results over time.
Oh wow! And so this is across lifespan.
Yes.
Wow. Okay, that's incredible. I wish we had that in more countries. Because I don't think we have it in the U.S. after you turn 18.
No, it's different.
Yeah, very, very different.
But we can also learn from the results from Sweden and from countries that have this type of surveillance. We can also learn from these big groups of children. Yeah. So I think it's important to remember that our children in Sweden, they gain a lot of interventions, and they get like aids and equipment for free, and our healthcare is free, but they still get contractures. So
have you been able to decrease the CP levels, like because you have a follow-up program? Does that mean that people have less surgeries, or I don't know, have less contractures, or?
A bit. Not. We're looking into that now. When it comes to contractures, we will look at the prevalence of contractures for each year, mm-hmm. to see to what extent they have decreased or not. Mm-hmm. But we have also managed to decrease, for example, the levels of hip dysplasia, mm-hmm. but that's not because we have. It is because we're doing earlier surgeries mm-hmm. for the hips, yeah. And the same for the scoliosis. We are normally doing earlier surgeries because we have seen that
the patterns
are showing that they are.
And you mentioned something very interesting, a statistic that I wanted kind of to raise my hand and ask, but like everyone else was having these really profound medical questions, and I was like, okay, this is a tiny question, but now is my chance. You said something that women are 40% more likely to develop scoliosis. Why is that?
That's a really good question, because we don't know. We just see it, but we don't know why. And that's unique for the scoliosis, because a lot of other symptoms of SEEP is more common in boys than in girls, right? Or equally mm-hmm. divided, but scoliosis is more common in girls, and we don't know why yet.
The data yet. And then also you mentioned something about heart failure and then a lung, well, not lung failure, but that lungs don't function the way they should after a certain percentage. Is that correct?
Yes, yes. And that's why it's important to intervene and to treat scoliosis, because it's health threatening to have a very severe scoliosis.
I've always wondered if I will develop scoliosis as an older adult. Can that happen?
Normally, it doesn't happen for adults with a lower level of GMFCS. Walk, like you can walk, so it's much more common for non-walking children and adults. But for adults with more severe forms of CP, they can develop scoliosis in adulthood. If we have managed
this speaks to the importance of continuous surveillance.
Yes,
right.
It does.
And actually, one of my final questions to both of you is going to be, you both, do research in different ways, the biology, the molecular, the muscle level things, and studying the trajectories. And what are the gaps that you still see that are still missing? I mean, we mentioned some of them, right? You said we don't have an answer to that, or but what are some gaps that you see in your fields and you say, oh, I wish we would study more of this or that? What is something that needs to be studied more of? Perhaps we can inspire future generations.
I can think of two things that I would really like in the future for both my own research and kind of as a community. That would be for whatever biological sample we take, we try to combine it with clinical history. And there's CPUP data, for example. We're fortunate to operate in Sweden, right, where we have this fantastic big data set, right? That's also continuously being collecting data. So for every biological sample, have a good clinical history. I think that will help us.
Right.
And then also to do the studies that we say now that we don't know. Understand both what happens early on when you have CP, the little kids, but also then when you try or when you enroll in let's say you start doing exercise more frequently. How does your muscles respond? How does your body as a whole respond to that from a molecular and biological standpoint? So before and after samples, those kind of things. I think that will be really cool.
So for any medical students listening in Sweden, please, or anywhere else in the world. Dr. Cloodt?
Yes, I agree what Ferdinand said. And also I would really much want to look into the question that everyone asks. How can we treat the contractures that has developed? We're doing a lot of interventions that also puts a lot of pressure on the children and the families. And that was actually the reason why I got into this field of contractures, because I met a teenage girl when I started my physical therapy work, and she was so tired of all the orthosis. She had to stand in a standing frame every day because she had knee contractures, and the physiotherapist was so stressed about those contractures. So she had to put in a lot of hours every day to do something that she didn't like. And so I started this research journey because of her, and that I wanted to know is it fair to the children that we are forcing them to do all of these things, if it doesn't have any effect, or does it have effect?
You don't know.
So I think that's something I want to continue to
and
investigate.
let me just mention that Dr. Cloodt, you have a book that you collaborate with. It recently came out, Caregiving for Children. Please remind me of the name. It's skipping my mind right now. But
Caring for Children with Neurodevelopmental Disabilities, stories from pediatric practice.
And these are stories from the clinic. Tell me a little bit more about that, because I know it came out.
Yes, it came out just some weeks ago.
Yeah,
it's a collaboration with a doctor here in US, and he's Alfred Scherzo is his name, and he has a long experience of working with children with disabilities. So he has collected stories from all his years as a medical doctor, and all the challenges you meet, and the challenge that families are having. And he has, so each chapter is a story of a child, and then we have collaborated on each of these stories to create some reflections and some questions that can be used for working groups to reflect and discuss on these challenges that we all meet. So I think both families and clinicians can recognize themselves in these stories.
Yeah,
so
I love that. Thank you so much for doing that. I think we need more of the voices of the people, of the parents and the children. You know, what do they go day to day, but also the clinicians, right? Last question, and it's coming from a doctor in Mexico, Juliana Rodriguez, and she's a physical therapist, by the way. How does an interdisciplinary approach influence the decision-making process between surgical intervention and botulinum toxin treatment in children with cerebral palsy? And what are the long-term functional outcomes of each strategy?
That's a very big question from your colleague there. I would say, first of all, Sweden is maybe a bit different because orthopedic surgeons are also the ones that administer Botox. So I think Botox here is in Sweden is part of kind of the toolbox of the surgeon also. And the way it's used now is typically to postpone surgery. I'll let Erica elaborate on that, but I can just say that typically now all the data that's in the literature when it comes to muscle, every sample that's being analyzed has a treatment history. And as I said, it's not really that well documented. It doesn't really come out in the papers. But we're working now together with Dr. Eva Ponten, who you might have run into here also at the conference, to really assess molecular and histological changes of repeated Botox injections. So that's data that's going to come out in the next year or two. So that I think that will also add to kind of the so you can make an educated decision-making process there.
Thank you. Anything you would like to add, Erica?
I think the surveillance program helped us by being so regularly that we are seeing the kids so often, and we have these discussions together as a team. And when we follow the function of the child, we get a lot of information that also helpful for the orthopedic surgeons in decision making. So I think we very much benefit from each other's work in many ways.
Collaboration is so important.
Yes, definitely.
Well, it's been my pleasure. I know it's gone longer than expected, but I have very good news for the listeners of this podcast, and I know a lot of people are going to be very, very happy, and which I am eternally grateful for. I have asked Dr. Van Walden and Dr. Cloodt if they could share their slides of their presentation with me, and they said yes. So if you're listening to this episode, which I really hope you are, because I know a lot of you really wanted to attend this session, and you would like access to these slides, please send me a message and I will pass the information along. This is what collaboration is about. These are doctors in Sweden. I'm from the US, but I'm trying to be a bridge to doctors in Latin America, all over the world really. But I'm so happy that both of you have said yes. I know a lot of your colleagues in Latin America and Spain and everywhere else are going to benefit from your work. So thank you so much for saying yes.
No problem. That's what it's about.
Thank
Dissemination of knowledge.
Absolutely.
That's it for today. Thank you so much for joining me in another episode of the Cerebral Palsy Answers podcast. And remember, if you have any questions regarding cerebral palsy in Spanish or English, please submit your question to cerebralpalsyanswers@gmail.com or head over to my website, www.azucenagarcia.com, and you can submit your question there. Thank you.